Hi, this is Shanna Miranti. I'm a dermatology PA from Naples, Florida, and this is Let's Talk About Acne. I'm here today with two of my mentors in the field of acne. These are two iconic dermatologists who have quite literally taught me most of what I know about acne, since they have been my trainers in speaker trainings for many companies, for many products over the years. And I'd love to debunk some myths today, ladies. So if we can go through a few of the myths associated with acne. First off, does food cause acne? All of our parents are concerned about it. Does the junk food and the gluten and hormones in the food actually impact patients' skin?
I don't know.
Great answer.
Yeah, we're done.
Yeah, right, finished. Guy Webster is known for being very succinct with yups and nopes.
Yes,
so
yes.
My answer is I don't know. We can go through the data. We know that there's some data that indicate that high glycemic index diet might make acne worse, that an abundance of particularly low-fat and non-fat milk dairy products in general might make acne worse, but we just don't know. I'm absolutely convinced that whey protein supplements are a problem, but the other two I just don't know about. And I had a patient who came in the other day whose dermatologist told him to stop eating gluten, just point blank, no gluten, no dairy. He's 14 years old. No dairy is not a good idea, nor is it possible. And the onus that it puts on his mom to come up with food for the entire family with those restrictions is just enormous in the absence of data.
Having teenagers myself, I think something like that would completely derail a family.
Right.
Yeah.
And it's impractical, unless you had hardcore data showing that it absolutely was causative.
Exactly. And that changing the diet fixes it.
Yes.
Because it may not.
Yes.
I've never had a patient go on a dairy-free diet and say, wow, that made a difference. Often the patients come in saying, I haven't been eating dairy for the last 2 months and it hasn't made a bit of difference. So I just haven't seen it making a big difference, and it's just so difficult to do.
You make a good point with the whey protein, though, because there are some foods that are potentially androgens, or androgenic in nature. There are certain foods that are, plant-based hormones or have plant-based hormone associated with them. So there may be something there, if we're thinking about hormonal acne.
I think there is, and there's also a substitute for whey protein, which is very different. All mom has to do is buy a bucket of egg white protein instead of a bucket of whey protein. Problem solved, without disrupting the rest of the family.
That's a good point. That's a good point.
And I will say I agree with all of this. I still do not usually bring this up first.
Never.
Because I don't think we have enough data to do that. Now the whey protein may be the exception. Especially if I have somebody in front of me and I can tell that maybe they're working out, they're athletic, that may be something that I ask proactively. But in general, this comes up when the patient or the mother or the father, whoever's with them, says, hey, they've been eating too many French fries and drinking Coke or eating pizza. Can you tell them to stop? And then now we've got to have the discussion, and I bring up the exact same things you do. And I think we need more information. It is not bad for anyone to eat a lower glycemic load diet, but avoiding gluten, that is difficult. Avoiding dairy completely is difficult. So I don't bring it up, but when they do, we do have an answer.
I think
An answer for now.
Mothers forever have been telling their children not to eat something because they didn't want them to eat it. That's going to make you get acne. That's
exactly.
And it just there's no data that supports it.
And that could run right into another myth that comes up the same way. So the mother or the father in the room will say something like, they've been wanting to wear makeup. Can you tell them that they don't need to wear makeup? And I always kind of look at them like apologetically, like, no, I can't tell them that because there are choices that they can make. And I think it's important for people to, while they're going through treatment, while we're making their acne better, that they're able to do things to make themselves feel better about themselves. And so as long as they're choosing makeups that are non-comedogenic, that are not super heavy or occlusive, I've heard Hilary say, especially in rosacea patients, really more than acne, we need to use products that aren't so hard that you're scrubbing them to get them off. But no, patients who have acne can wear makeup. The makeup is not causing their acne.
That's a wonderful point, because I feel like I'm the mother of 4 children. I have 3 daughters, and there has never been a generation before this current middle school, high school generation that is so knowledgeable
on skincare.
On skincare.
It's true.
They
crazy.
come in, they
It
already
is
have
true.
their regimen.
Right.
Their favorite shopping cart is Sephora. You know, they do go to,
Yes.
and they come in loving certain products. And sometimes we have to say, this is an oil-based product.
Right.
And it may actually be
Right.
harming, you know, your acne situation. So how do you ladies go about talking through those, you know, those things with your patients? First of all, convincing mom that it's not a hygiene issue. It's not
Yeah.
because her son isn't
Right.
just
Right.
not showering. And
Although
then how do we
sometimes that doesn't help.
Right.
Yeah,
Right.
but it is not hygiene. People
Right,
do
right,
want to. They want to say they don't wash their face. This is all
You
from
have
dirt.
to go through
but,
the bag. That's what you were going to talk about. The gigantic bag of
Yes.
stuff that they
Oh,
come
for
When
the
they
in.
come
girls,
in, when they
for the
come in
girls
with
you
their
do, but
products.
the boys have nothing. The boys are using their shampoo or whatever it
Yes.
is in the shower to wash their face. with.
one thing from head
Yeah.
to toes?
Right.
Yeah.
Yeah, but that bag is deadly, and you take it out and it just lines the whole countertop. And you know, our rule has always been with treating patients is KISS, right? Keep it simple, stupid. And now all the girls want to do, they want 10 products that they're supposed to use. One Christmas, not too long ago, my daughters asked me for Christmas for a skincare regimen. I gave you a bar of soap. We're done. Finished.
But I think oftentimes when the normal, you know, middle school girl goes and asks her mother, you know, what is her mother going to recommend? Okay, well, let's go to the dermatology office, but then she's waiting months to get in. So they do bring them to, you know, it used to be the Clinique counter, now they're bringing them to Sephora and Ulta. And the salespeople are oh so happy to sell them a myriad of products for different things, which may not be helping. So.
Well, and I think, you know, just being reasonable with them. I will talk sometimes about, with the patient's language I will use is, well, my doctor's side feels like this, but my girl's side
Yes.
thinks that sounds really fun, and I would like that
Yeah.
too. But let's take care of the doctor's side first, and then once we get you better, the goal will be to do things that don't do any harm. There may be a way to bring some of these products back in that you enjoy using, but right now, when we're treating acne in particular, I need you to pull back, let me get you better, and then we will help you to know how to bring those products back in.
And
Because
loved
I
what-
get it.
Yes,
you know,
and I love what
get
Dr.
it.
Eichenfield said on podium. She said, you know, if they have a favorite toner, let them use it.
Right,
Let them
right.
incorporate it. Because
I
if they're
agree with
already
that.
married to that product,
I agree
if
with
they
that.
love a cleanser, I don't always make them change it unless
Right.
it's a cleanser that's going to be additionally
Exactly,
irritating or they have to scrub it
exactly.
off. So if they have a particular product line that they really love, let's work with that.
I agree.
And then I think that'll only help drive compliance.
Right.
Because when the patients feel listened to and they feel like they are, you know, that we are hearing them and what's working, because they've been working on their skin longer than we have.
Right.
So we need to listen and pay attention there.
Yeah, I think that's great.
Yeah. Okay, third acne myth, benzoyl peroxide. Does it cause cancer? Dun, dun, dun.
Who wants to go first on this one? So benzoyl peroxide itself is not a carcinogen. And so, you know, if that is out there, that is in fact a myth. But benzoyl peroxide can, under certain circumstances, break down to benzene. Benzene is a carcinogen. So we've got to do our best to make sure that benzoyl peroxide doesn't have a chance to break down to that. And you do that by following the instructions on the label, by shipping products cold chain, like the Cabtrio product comes to us cold chain. The samples come to us refrigerated. And I have started, you know, I certainly am still writing benzoyl peroxide. I'm writing Cabtrio right through all of this. I never even took a pause with this. But what I have done to be on the cautious side is look at patients and say, you know, you can keep this in the refrigerator if you want to be extra cautious. But at the very least, let's keep it at room temperature and don't keep it past its expiration date. But I think I'm willing to go so far as to say it is a myth that benzoyl peroxide is a carcinogen. It is not. That's still on the FDA webpage where they say it is generally recognized as safe and effective.
I totally agree. I tell my patients, go through your closet, throw out everything that has benzoyl peroxide in it, because it's probably been in your medicine cabinet for 3 years. Throw out everything, start fresh, keep it refrigerated or keep it cool. You know, in the summertime, I don't know how everybody else lives, but, you know, we don't have central air in apartments in New York City, so we turn off our air conditioners when we leave the house in the morning. And
We do not do that in
gets-
Alabama.
Do not
Right.
do that in
Or
Florida.
Naples, no.
Right.
It gets really hot. So I am in New York asking people to keep it in the refrigerator. Also not to keep benzoyl peroxide cleansers in the shower, which we know can get hotter than everything else in the house. Although I'm sure we're sealing the fate of that cleanser. You know, how many times have you gotten into the shower, realized you didn't have what you needed? You don't get out and walk with sopping wet to the kitchen to get it. So it's a real problem now with compliance. But I agree. I'm not the slightest bit nervous, especially with the cold chain products, and you know, and obeying the expiration date, which is a little tough, because the expiration date is, I think, 10 weeks, if I'm not mistaken. And if they're just using it on their face, they probably haven't run out. And then it feels kind of bad to toss it. But I think until we hear more from the FDA, that's what we have to do.
I think this is going to be very reassuring. You both have been past presidents of the American Acne and Rosacea Society. I think what Dr. Del Rosso and the AARS has been doing and the messages that have been coming out are very reassuring to providers that are out there that want to have answers for their patients. So I do believe that, you know, it will be wonderful to hear this, and just again reassuring for those of us who are trying to do best. Because we don't want benzoyl peroxide to go away.
Right.
No.
Right? It is
Well,
such an important medicine.
It's such a good point. We have to balance this. What are we going to do without benzoyl peroxide? How are we going to prevent the development of antibiotic resistance to either the topical or the oral? It's such an important drug. And you know, if there's just a glimmer of the possibility of a small 0.0001% chance, I'm going with the benzoyl peroxide.
Mm-hmm. I'm with you. It's been on every single treatment recommendation list, on every single AAD recommendation list. Let's go through those new AAD recommendations. Of course, as both of you know, we have had a lapse in guidelines from 2016, I believe, until 2024. And the brand new AAD guidelines just came out earlier this year. Now, they did come out preceding the launch of the triple combination Cab Trio. And I do feel like, you know, although they were very conservative in their recommendations, there were a few misses. I think that you know, it brings up a good point about benzoyl peroxide needing to be in every single category. So how do you use the new recommendations in your practices, and how are you going to you know, move forward now that they are out?
Well, Julie, you were the first to come out and say some very important things about the guidelines.
I do critique them to a certain extent. I do want to congratulate the authors. There's a lot of really good information in there, and the parts that I love are where they stayed, in my opinion, very objective. So they were looking at the strength of the studies and making recommendations based on data. Because at the end of the day, these guidelines, yes, they're for us, but they are going to determine, whether we like it or not, what drugs my patients have access to.
Absolutely.
And I want them to have access to as many as we can. Now, if there's good data to support it.
Because the payers will be paying attention.
And
so
that's one of the problems that I had, is that, and it did kind of call out some branded products that are not available as generics yet, and it called them out in a very subjective way and lowered their recommendation status based on cost. And I think cost doesn't belong in the guidelines, in my opinion. If it is in there, it needs to be there in a more objective way. If we're not careful, what I'm concerned about with that is that if a branded product is always going to get a lesser recommendation, who the heck is going to bring us the next branded products?
Right.
And although we're getting better with Cab Trio, we have not solved the acne problem. We still need innovation for our patients.
Absolutely.
And the people who are bringing it are having to pay an awful lot of money to bring it, and they have to be able to you know, get products that are covered by insurance in order for that innovation to continue. So I was a little disappointed in that part. I've been vocal about that. I will continue to be vocal about that. That is not about me, that is about my patients.
Absolutely.
Keep those things out of my decision making for my patients.
For sure.
Let me make decisions based on the data of efficacy.
Absolutely.
I couldn't agree more. You know, you beat me to the punch, but I would have said everything that you said, not as eloquently, but I would have said everything there. You know, since medicine began, we've been talking about risk versus benefit. And what this guidelines did was risk and cost versus benefit. And I understand that the cost of medicine has gotten out of hand, and I understand that that means that there's inequitable distribution of medications. And that's unfortunate, but as Julie said, we need to talk about all the medications that are out there. And by giving a conditional approval to these 2 branded medications, that it sealed their fate in terms of the pharmaceutical, of the insurance companies allowing us to use it. So now we're done, basically. And then they said, well, we'll reassess it for the next guidelines.
When are
8
those
years
coming
from
out?
now? Right? It's just, I found it very disappointing. And then the things that I felt that I really needed guidance on weren't in there, like guidance on cumulative dose of isotretinoin. They didn't even mention that. They also didn't even mention extended release minocycline as being easier drug to take, for example, than immediate release minocycline. So I didn't love the guidelines. I'll just actually say that. But I agree with you. It's a terribly difficult job. And I applaud them for the effort. I just don't agree with the outcome.
And ultimately, if it's going to affect, the payers and going to affect access, I think that's why we get so passionate about it, because
Yes.
we want to give our
It is.
patients options.
Absolutely.
Our patients have the option to go and buy a Tesla or a used Toyota.
Right,
They have
exactly.
the option of buying a super high-end purse, or
Right.
a Target brand purse.
Right.
They should have the option.
I agree.
And when it starts,
That's
when
well said.
decisions start
Yeah.
impacting
Yeah.
what I'm going to be able to prescribe, because now the PBMs say, oh, sorry, you can't have that anymore. That's
Right.
unfair to the patient.
I agree.
Especially
Absolutely.
when objectively the efficacy is there.
Right.
And especially in the case of clascoterone, when it's the only drug in the class.
That's right.
Well, the same too, clascoterone and sarecycline, I think there was another one in there too, that were given these conditional recommendations based on cost, also had the strongest data.
Yes.
So it wasn't that they had moderate data and then this. They had the strongest data and then still got a conditional recommendation. So,
And the level on par with salicylic acid and azelaic acid. That's just not what that data suggested.
I would have to agree. I think we can all agree that this is an incredible era to be treating acne, right? We are very blessed to be in this fabulous acne era. And I'm very, very grateful to be here today with Dr. Julie Harper and Dr. Hilary Baldwin. So stay tuned for more episodes of Let's Talk About Acne.